everybody. My name is Eric Boyer. I'm the Senior Program Officer here at the Alaska Mental Health Trust Authority. And it's our pleasure. We've been working really closely with many of you. And if you're new, this is great to have you join us and learn more about the role of peers and the role of a peer support specialist in the crisis stabilization work that we're doing across the state. So I want to introduce you to Amy Pugsley, who's the Executive Vice President for RI International based out of Phoenix, who has been doing a lot of this work around the globe for a lot of years, and we really appreciate her leadership and expertise that she is supporting many of our providers around the state with. And then one of the staff at RI is Lisa St. George, who is here to provide the presentation, and she's really one of the foremost experts on peer support and the roles they play and the skills needed and the trainings developed to support them in crisis work. So with that, I will pass it over to you, Amy, and thank you for you and Lisa joining us today.
Yeah, absolutely. Thank you so much, Eric, and hi to all of you. It's good to see so many faces that I've been working with and some new ones as well. As Eric said, I'm the Executive Vice President for RI International, and part of what I do is oversee operations of crisis facilities and outpatient services and community services throughout the country, as well as help on this consulting front around helping communities really start these services or grow these services if they already have some level of it in their communities, to really help the continuum to come to fruition wherever they're at. And so we're going to be hosting and working with the trust around a series of webinars. And we thought that it was very fitting to start with peer support services in crisis. And the reason for that, Lisa St. George, which I'll let her kind of give her background and history. She's definitely a thought leader in this area. She's a pioneer in all of this. And one of the things that I would say, even as Lisa has been with us at RI for so long, is really tailoring and tweaking and continuing to evolve what peer support specialists are, and that service really means to all levels of care, and what it means to crisis services, and why it's so key to being able to really help people when they're in crisis, stabilize and return quickly back to the least restrictive environment. And it's all about how we do that and how we integrate peers into our crisis services model. And we want to help be able to share that success with everyone, so that people can really help communities in kind of reaching people where they're at and helping them along their journey. So with that, I'm going to turn it over to Lisa, who's going to be our presenter today, and let her introduce herself and get us all started. Lisa?
Hi, everybody. I'm so glad to be with you today. And my role at RI International currently is Vice President of Peer Support and Empowerment. But I'm a social worker by trade. I've been a social worker for about 40 years now. Worked a lot of different systems. But I've been doing this work in behavioral health for the last 23 years. And I have my own lived experience on many levels in different ways. And so it's become a huge passion of mine, because I've seen over the last 23 years the immense benefit that peer supporters bring to systems of care, people with lived experience who are willing to share that with those who are receiving services, and how helpful and inspiring they can be to people and to systems. So we'll talk about that a little bit today. But I do want to start out by saying that it's always a guess when you make a presentation like this, what people need to know. And so I'm not assuming that you don't know any of the things that I'm presenting, but this is my starting place. And so I don't want you to hesitate to jump in and ask the questions that are burning for you if I don't approach those and discuss them. And so I'm really willing to have a conversation here today. I don't have to stick to my PowerPoint, but it's there to guide my presentation to you. But I know we have some experts on this call too. And so I just want you to know that we can have this go in any direction that you want. I'm going to also ask you to forgive me because I have a really bad something going on, and that's why I sound like I have a clothespin on my nose. And I might have a coughing fit, so please forgive me. Not intentional, not to disrupt this, but let me see. I need to share my screen. And I am not used to sharing on this Teams. So let me just know when you see my presentation in
Yep, we
format.
can see it, Lisa.
Okay, great. Thanks. Now I can't see any of you, so just be aware of that. So
I can monitor chat for you.
great, thank you very much. And if someone has their hand up, please let me know. I just saw Amy pop up, so there might be a way for me to see you. So I have it, of course, at the end of the slide, so just let me back up here. Sorry about that. You know, at RI, we have a particular way of looking and working with people and doing this this work, and we call it fusion and the RI way. And so that's kind of what I'm going to give you in addition to some other things. But the idea of fusion is to fuse together the excellence of clinical support with wonderful and excellent peer support. And those things together, the lived experience and the clinical expertise, are what we feel gives people the best opportunity to experience recovery. And one without the other is strong, but when we put those two together, it's amazing, especially for people who are in crisis. I have my email up there and my phone number. If you would have questions after this that you need answered, or you want to discuss something or anything, you know, please feel free to reach out to me, and I do respond pretty quickly. I try to respond quickly. So what we'll be doing today is we're going to be looking for you guys to be able to discuss systems change and how to support systems change, like to this 988 process, or to a service system that now includes crisis services, or what we are really learning are emergency behavioral health services. And that we're hoping that you'll be able to name some ways that people with lived experience are vital to our service systems, and to talk about important aspects of peer support, career ladder, peer support supervision, and what we call the tipping point. And be able to talk about at least 4 aspects of a fusion model and peer-powered practices. And then overcoming reservations and concerns about hiring peer supporters into organizations.
Hi, Yamala.
Lisa,
Hey,
I
Lisa,
don't think your slide is moving forward.
Yes,
Is that
the
what
slide
you're
is not
Becky?
moving forward.
Yeah, we're still on the first slide.
Oh,
But I think you're talking about your objectives, so I think you're about slide 3 or 4 for you.
yeah.
I wonder if maybe they're wrong. Yeah, it looks like you're still in like the PowerPoint or the like the slide view. So if you click the slideshow view, yeah, that button you were just on.
Let's try this again.
Start advancing for you.
Thanks for stopping me.
Yeah, it's good stuff. We want them to see it too.
Now, do you see, just tell me if it changed now. Did it change?
For some reason, it's still, I saw you clicked the PowerPoint, the slideshow view, but it didn't change on the screen. I wonder if Teams is just sharing the wrong screen.
Okay. Let's see if I can do it this way. Okay, let's go back a little bit. How about now? Does it change?
We're not seeing your screen right now.
You have to share again when you change.
I'll tell you what I'm gonna do. I'm gonna unplug my other screens that I have, and I'm gonna just use the one and see if that makes it work.
Oh, hi, babe. What you gonna eat? Oh, okay. From Mind Palace. Oh, that sounds good. Better
The
than
joys
what
of technology.
Goodness gracious. Okay. All right. How about now? Is it
Not
changing?
seeing anything, Lisa. I have your slides actually from what you sent me. So would you want me to just share and then hopefully
Yeah,
That
that
would
works.
probably
might
be the
be-
best thing to do. It would be the one that I just sent you yesterday.
There, that's great.
okay? Is that showing up in the PowerPoint or in the presentation view? Okay, great.
Yep. Okay, there we go. Sorry, did enlarge my now a little bit so I can see it. Oh, that's your screen. Come on. I don't know where it went. Oh, there it is. Okay. Now I see it. So there are the objectives that we just talked about, and you can go to the next slide. And so when I talk about people with lived experience being in our systems of care, I mean people with mental health challenges of all kinds. So it's not, excluding any kind of mental health challenge at all. Even the ones that people think, maybe can't do this kind of work. I've seen people from all kinds of situations and with all kinds of lived experience of mental health challenges do this kind of work and be really expert at it. I mean, people with substance use issues. I mean, young adults. I mean, older adults. I'm family members of people who have mental health challenges or substance use challenges. So all of those people in my mind are people with lived experience. So in addition to their presence being able to help people we serve, what I have seen happen over and over again in Arizona and throughout California and in New Zealand and England when we did work there and helped them start their systems is that the service system itself begins to recover as peer supporters step into it. And what I mean by recovery of our mental health systems of care is that people, especially in the past, we used to work from this reference of when you get a mental health diagnosis, that's it. That's it for you. And myself and many people that I've met in this work were even told they should never even work or hope for having meaningful relationships in their life or even think about getting married or anything like that. And when we have thinking like that going on, when we're serving a group of people, we're basically saying nothing can change for you, which devalues the work that we do, right? So when we have people start recovering and working alongside us and we see their lives changing and we see the good work that they provide and the good work that we provide alongside with them, our whole system becomes more hopeful and it begins to change. The language being used changes, everything changes for the positive. So I would just want to talk about it through a motivational interviewing kind of lens. If you could switch the next slide, please. So in the early in the 80s and early 90s, and in a sense, and long time before that, we were in pre-contemplation. And it was that time when there was no hope for people. when, people got their diagnosis and it was thought that that was it for them. They could only hope to cope. And as Patricia Deegan, says, that's nothing to think about loving on a Saturday night. And so if you just think that people can take their meds and sit down in their house and do nothing, that's where the system was living. And so I call that pre-contemplation. And then in the 1990s, Dr. William Anthony wrote a book about recovery. And he started to understand that recovery was possible and it was a real thing. And slowly, the systems of care, people working in them, began to take notice of this. And then by 1998, Georgia and the state of Arizona began to include people with lived experience in huge ways in our service systems. And so at that time, especially what I know is in Phoenix, we had people coming from not just across the United States, but from around the world to see how we were working with those people, because they didn't see this as something that they had ever thought was possible. So they used to come to see what we were doing all the time. And I call that they were starting to think about things maybe being changed. Maybe we could do this differently. And that's kind of that preparation thinking if we look at it through motivational interviewing. And by 2008, SAMHSA took that huge step and identified peer support as an evidence-based practice. And that really moved everything into the action phase. And what built on top of that was the VA beginning to hire huge numbers of people with lived experience to work as peer supporters, because who can help a veteran better than a veteran? Who understands where they've walked better than someone who's walked those hard trails like them? And so they saw the immense value that they brought to veterans. And so while certain parts of our system were already in action, other parts were just beginning to start thinking about contemplation about, could this be real? And so we're all at a different place in this process, but I think that a lot of systems now are in a maintenance stage. And when we look even at when COVID hit, peer supporters shifted and changed and went online to provide classes just like everybody else did. And we know that with the passage of 988, peer support is mentioned in all of those Crisis Now descriptions that are included in that 988 toolkit and description that was passed in 2020. Next slide, please. And so when we're going to make a big change like this, some of the things that I've seen happen and I've learned over the years that are important are that the system itself wants to provide information to all of the providers, all of the stakeholders, the families, the people who use the services, all of the facilities, all of the organizations, everybody who's working together about where that system is trying to get to, and talk about that roadmap for change. Like what are we going to do first? What are we going to do next? What kind of help do we need from everybody? And to make sure that everybody understands that they all have an important role to play in this, and that it will vary depending on what people do and who they are in the system of care, but that everybody needs to be at the table. And the system that's trying to change needs to be very transparent, and people and organizations need to be transparent about the things that they're concerned about so everything can be addressed. And the other thing that's really important when you're trying to make a huge change like this is people being patient with each other and being able to ride over those bumpy places if you know what the goal that we're trying to get to is. Because there will be bumpy spots. There will be things where, things will come up and it'll be hard or difficult or confusing for a while, but it will get to the place it's going for if you have that roadmap laid out and and everybody's trying to move in the same direction. One of the things that I've seen is really important in that kind of a process is having the voice of people with lived experience at the table. in more than one, more than two, in larger numbers, so that we really hear their voice about what works for them and what doesn't. Next slide. So some of the common concerns about hiring peer supporters are, I think one of the first ones that I hear quite frequently to systems that are considering this change is what about confidentiality? What if they know people that they're serving, and what about this and that? And people who are working from their lived experience also have to follow HIPAA. So that's not just reserved for clinicians. It's also part of the ethics of peer supporters and people with lived experience as they enter the systems of care. So they can't go into anybody's file, just like you can't go into anybody's file. There has to be a reason that you're looking at things. What about peer supporters and their well-being? People often ask that question, organizational leaders and things. And all of us, and as we've seen from COVID in a huge way, we all need to manage our well-being. And it's not been my experience for the last 23 years. And I've managed hundreds of team members at one time in multiple programs. Over about 15 years, that was my main work, was multiple programs with peer supporters. I've not seen them have different mental health needs than anyone else. What I've seen is that they want to do a job, they want to be valued as an employee, and we all want that. And so all of us need to address our well-being. And the other question that comes up a lot is, what do they do? And so it depends on where they're working, what they do. And they need to be doing the kinds of things that you identify that are important for them to do in your workplace. The challenge for peers is when they're relegated to simply sitting in the lobby greeting people or something like that. If that's an important part of their work, great. But we shouldn't think that they can't do documentation or really serve people who are in the midst of a crisis. They can do all of those things and more. We have peers working in housing programs, in educational programs, in all of our crisis services, in respite, in crisis respite, temporary housing, all kinds of programs. We have people with lived experience fully integrated into all of those teams. Next. The next question that comes up a lot is who supervises them. And I think I'm going to get into this a little bit more later, but what I'll say right now about it, just to be clear, is that who supervises them is who you have to supervise them. But every supervisor needs to be trained to be a good supervisor. And supervisors of peer supporters must understand their work. Now, as a person with lived experience, I would say that most peers would prefer to be supervised by a person with lived experience. But it can be anyone as long as they understand what their role is and don't try to either turn them into a mini clinician or keep them from doing their full scope of work because they're fearful. So all of us need to be better supervisors. And so what kind of special needs do they have? And I remember when we took peers into the hospital, the nurses were very, very worried that they would have to be taking care of the people with lived experience who were coming to work on those units. That didn't happen. And for the most part, peer supporters manage their well-being through their own tools like RAP or other things that they've developed over their life to be able to manage their things. The thing that we need to accommodate for, as we would accommodate for anyone, is medical appointments, if that's something that they need, or therapy that they go to. But anyone would be accommodated for that in a workplace. So it's not something extraordinary. Next slide. So certification of peer supporters is extremely important. And the reason is there's helping, and then there's helping effectively. And so sometimes people think of helping as doing everything for somebody and making everything okay. And that is not effective helping. And so one of the things that people learn as they go through certification training is how to help people in ways that inspire them, create independence in them, create a belief in self, and develop their autonomy and their confidence in themselves. And that doesn't happen when you're caretaking people. And so just like everybody else who works in our system, we've learned that kind of the hard way, that kind of help creates learned helplessness. And so if we want our peers to work effectively, they should have a training that teaches them things. The other thing that comes from certification training is that peers will get ethical values identified and laid out for them. And so some of those ethical values that would be notable would be that, there shouldn't be any giving of personal phone numbers or taking of personal phone numbers of people that are served. And this is something that can happen if people don't have a good ethical foundation. And I can do a whole training on why that's not helpful, a whole nother training on that. But, if you just play it forward a little bit, you can imagine the results of that. Even if, it's a very small system and people know each other, shouldn't be an exchange of phone numbers. Engaging in relationships outside their relationship in the workplace for people served and people working within that system should not happen. And no business, no money, no exploitation of people that are served. When we have a system of care that's probably like in Alaska, where there's a small community and everybody already knows each other, that creates a different scenario. And people will know each other, and people might be neighbors to each other. And still that can work out fine, but people need to have an agreement on how they will handle that relationship in that shift that will take place if they begin working with an individual as a peer supporter. Next slide. So it's important to include people with lived experience in more than token roles. You won't be getting the best out of what they can bring if you keep them in a token role. Bringing peers in to do really good work is an important part of the growth and the change in the system of care. I never like to see one peer supporter or even two. It's depending on how big the organization is. It should be sort of a ratio of peers to the other people that work in that agency. And you should be able to feel their presence. That's what I call the tipping point, is that, what is the number at which you have enough peers on your team that you start to feel their presence, because you start to see the impact that they have on the people that they serve. And you might not notice that if you only have one person. It contributes to the diversity, equity, and inclusion of your teams, because a lot of times the peers will be coming from the community that you serve. And so they will be the same kind of individuals that are being served. And so we start to build diversity in that way. We start to build a service system that looks like the people who are being served. And that's really important in terms of safety for people to feel comfortable and hopeful there. Everyone's opinion is valuable, and learning to negotiate and come to agreement on things that are maybe going to happen in a different way because you have peers working now is an important thing to understand. And so we can work through things that are new and different, and sometimes they can lead to really amazing things. And then, develop that group of lived experience leaders throughout the system. So not just in organizations, not just in peer-run agencies, but in the Medicaid system, in the state, all through the whole service system, from, the funders, the planners, everybody should include people with lived experience on those teams. And that's what you'll see if you come to Arizona. If you would see peers in our Medicaid service provider system, You would see it in all the managed care organizations. You would see it in all the businesses. And in fact, I believe in Arizona now, all of the RFPs include a component of requiring to have people with lived experience working on teams. Next slide. Excuse me for a minute. When peers come and join your team, they bring so many good things. And they help, you know, it's important to help everyone understand the role and the work that they do. They are there to work alongside the other team members. They don't really have a different role. Like in our crisis center, our peers do the vital signs. They engage people. They are the first people that someone meets when they come into our crisis centers, because that creates safety and comfort for them to know that someone gets them, someone understands, and knows where they're walking. And so that is really important. But all of the team members need to understand what their role is. We shouldn't try to make them into clinicians. We should help them to, you know, inspire through the work that they do and the things and this particular way that they speak and engage with people. Another important aspect to include in your service systems is career ladders for people with lived experience. And so we don't want to just have an entry-level position that's peer supporters. We want to make sure that we have sort of what we have in our agency is peer 1, peer 2, peer 3, peer lead, peer manager, and then we have program directors and things that are people with lived experience. And in our organization, we decided a while ago to begin to, when we put our advertisements out for positions, no matter what it is lived experience is preferred. So we have docs and nurses and clinicians on our teams who also have lived experience. And if you don't know this, many people who go into helping professions have a lived experience of some sort or another, because that's why they become that. They want to help. They want to make things better maybe than what they experienced. And so we want people to work with us and know that they're safe to disclose, that they're valued for that, and that they can actually draw upon their lived experience to give them deep wisdom on how to do things with people and how to help. We want to make sure that peers have living wages, like everybody that's working should have a living wage, and people with lived experience are no different. And you might say, well, you know, you might have people who only have a GED, but they've been dealing with their mental health issues for 20 years. Those 20 years are years of gaining wisdom and understanding of how to cope with our service systems, how to access what you need when you're living on Social Security, which is really, no one can live on that, how to get by. And people learn amazing things about how to deal with really challenging situations when they're going through those 20 years. And it's like the University of Hard Knocks. It truly is. And so every time we teach a peer employment training class, we add up everybody's years of living, you know, with their mental health or substance use challenge, and we put it up there on the board. And it, you know, it's usually like 350 years of experiences in that room. You know, it's a lot of years. And so it's a valuable thing. And then, as I said before, just when you bring peers in, you start to see that your services begin to shift. The language starts to shift. If you have someone with lived experience standing next to you and you're a clinician, you're not going to talk about that person sitting over there who's annoying in the way maybe you used to. You're going to speak about that person maybe in a different way because someone else with lived experience is standing next to you as a team member now. And it just creates an awareness that maybe is going to be important to the recovery of the service system itself. Next slide. So yeah, this is the supervision thing. And so it's training supervisors. And I just was at a conference, and one of the discussions that was had is that people who go into social work or professional counseling or even nursing do not get supervisory courses on how to read budgets and things like that. And so all of us need to have better training on that. And if we're going to supervise peer team members, we need to have a good understanding of what their role is and a training on how they work, because they will share their story, and that's something that most clinicians are taught not to do. And in the beginning, when we first started hiring peers, the clinical team members were really uncomfortable with people sharing their story. But you know, the peers learn how to share their story in ways that are only helpful and that are only for the benefit of the people that they're serving. And I always say most of the time a peer or anyone working in our service system should be listening. But when we're talking as peer supporters, if we're sharing a piece of our story, that is not wrong. It's okay, because sometimes if someone else knows that the peer that's working with them was homeless for a while, or maybe went to jail, or used to have a substance use issue, and they see now that they're working, it's just like nothing has to be said. There's hope that comes there. And you almost can see it in a person's eyes. They light up and they think everything can change for me too if it changed for them. And so it just creates an immense amount of positivity. And then, of course, the team members, everyone should be safe to say they have a lived experience. Next slide. So I want to just talk about recovery practices. And these are just some of the things that we do at RI that are important. Next slide. So we actually now have come to a point where we want not just our peer supporters, but everybody in our organization to work from these peer-powered practice reference points. And that would be, you know, the little diagram there says inspiring hope. Number one should be an important part of what we do every day, all of us. Choices, offering people choices, empowering people, keeping them in the front driver's seat of their own life. Having a recovery culture, a culture that is endlessly hopeful and believes in people. Making sure that people have meaning and purpose in their life. It's like we can't just say to people anymore, go home and take your meds. Like, what is important to you? What do you hope for? And those are the things going to pull somebody forward in their life. And having that clinical expertise. And at the center of all of that is the individual that we're serving. And so some of our peer-powered practices very specifically are, we are strengths focused, and we want to have whole person wellness. So in other words, we're not just paying attention to the person's head. We want to pay attention to all of their well-being and all of those parts of life, like education and healthcare and work and nutrition, all of those things that are important in a person's life for their whole person wellness. We always want to work from a trauma-informed care stance. And this idea of no force first means we don't just restrain people or put our hands on them without, you know, it should be the last thing that we do. And I have a slide coming up that's going to show that you can do that. And you should know, for us, we consider any kind of touch of a person as a restraint. So if we put our hand on their arm, you know, in a way that's going to guide them, we count that as a restraint. So we count those kinds of episodes. And when I asked our team, you know, how often do you use a mechanical restraint? Because I had a horrible experience in restraints myself once. So I'm no fan of it. And they said, well, maybe like they couldn't even remember the last time that they put somebody in a mechanical restraint. And I sit on a committee and I watch them work with people, and I'm going to tell you the truth. There's been times when I've had tears come to my eyes because of the gentle kindness that I see them showing with people who are having a really hard time. So that idea of no force first is incredibly important in the work that we do, because for far too long, that was the strategy. It's like, if they don't do what we say immediately, we're going to put them in restraint. So that has to change. Next slide. And that collaboration with people, we want to do with people. We don't want to do to people. So we always want to include them. even when we think somebody is not really fully present, like maybe they're having some alternate reality experiences, we want to talk with them, get their input as best we can. So we're going to offer it up to them, even if they don't respond to us in that moment. They know and they remember that we included them, and so when they are ready or able, they will participate in the service provision. And we must know that even when we think that they're not paying attention, they are. And I have a lot of stories I could share around that, but I won't today. Next slide. So when we talk about the Do With guide, this is something that our Dr. Chuck, who's our medical director, who's the coolest psychiatrist that ever walked. Am I right, Amy? He's so full of love. He's just a wonderful person. And he said, he created this with me, and he said, these are the times when it's easy to do two people instead of working with them. And that is issues around medication management. And we have to, if we're feeling like, take your meds, take your meds, take your meds, can we find another way to say, okay, I hear that you're not wanting to take them at this time. Can we talk about it in 10 minutes? Can we make a plan around what will feel more comfortable to you? Can we work around some of these things that have to happen in terms of a way that will make it manageable for you? The other time is high risk situations, like if someone comes in and they're on substances and stuff and they're very aggressive and upset. We don't want to just jump in and put our hands on them and start trying to control them. We want to work with them. We want to see to their comfort first as best we can. Do they just need water and some food? Do we need to give them time and space to be able to realize the situation that's going on for them that they might not find comfortable? When people have suicidal ideation, we tend to want to feel like we have to jump in there and fix them and save them. And is there a way that we can talk about it, that we can work with people to set up a plan that's going to be helpful to them, and not just do the contract for safety, but really work with people on a plan for how they're going to keep themselves safe, because they have to be a part of that. When we have people who are on involuntary commitment, and in Arizona, we have outpatient commitment. I know we call it assisted outpatient treatment, but it's outpatient commitment. You have to do what you're told. And so when people come in and they are on outpatient commitment, the team can get very, focused on making sure that they do the things that they have to do. They have to take their meds and this and that. And we can still find a way to work with people if we have patience and slow down and make sure that we give that person space to talk about what's happening for them and find a way to work with them to get the needs met that we have and that they have. Sometimes staff can get focused on workflow more than working with people. And also sometimes those protocols around things that are not regarding safety, but that have to be accomplished, like timing of vitals and things like that, or when medications get passed out. So if someone doesn't want to take it at 5 o'clock when all the meds are passed out, can they take it at 5:20 if that's what they want? So just trying to develop flexibility in things that maybe seem like there could be no flexibility there. Next slide. So, the trauma-informed care practices are important. And one of those things that we find that's important is to help people understand what we have to do, what goes on in whatever kind of setting they've entered into, and to understand our perspective so that we can learn about their perspective, because all of us are working from a different frame. And when we forget that some people don't know what our frame is, it's a loss of communication. It can create a lot of misunderstanding. We always want to work with people in an open body posture, in a calm way, in that caring tone, so that we're approaching them with gentleness and kindness. Because if we approach people tensed up and with intensity in our voice, you know, for someone who doesn't know why you're doing that, you know, they only see themselves there with you and you're upset or you're tense with them. They start to interpret that in many different ways based on trauma usually that they've had in their life. And so they will get firm and you know, planning for what's going to go wrong instead of planning for what's going to go right. And so if we all be mindful of the trauma and the things that people are bringing with them and even our workforce is bringing with them, then we can create much safer and gentler environments for people. And everybody wants choices. So the best, again, I would say the best that we can give people is choices. We can offer them as many choices as is possible in whatever creative ways that we can to help them stay in the driver's seat. Next slide. So we want to look beyond that diagnosis that someone comes in with, because what we found is that it's very rare, especially in our crisis services, that a person is coming to us because they are having problems with schizophrenia. They're there because their life just blew up in some way. They lost their housing or their relationship or something went, you know, wrong, or they're feeling so hopeless. And so, you know, but what we've learned is that people are resilient. They are incredibly resilient. And we have to remember, even though in this moment they may feel like they're broken, we may look at them as if they're having a broken moment. But we have to remember that the other 364 days a year that they're not sitting in our crisis center or in our office or whatever, they are resilient. They are getting on with their life every day. And they have the kinds of skills and tools, if they can learn to organize them, or they can make things work for them in certain ways, and we can help them to find ways to make things work, they will make them work. And I've seen people get through amazing things that would bring most of us to our knees, and they get through them. So people are resilient. Next slide. So some of the ways to tap into that resiliency is to make an assumption that people know what they're doing. Like, when you felt this way in the past, what have you found to be helpful to you? You know, what have you done before when this happened? What kinds of things do you use every day that help you relax? And I know that you do those, but they're so important that we do those, because it's putting the person in a frame of reference that's beyond this moment that might be miserable. And they're reconnecting with those parts of themselves that are strong and resilient. The other thing is, like, when you go to work, or when you're feeling better from this, like, it's gonna pass. So really connecting to those parts of their life that are going to keep moving forward, or that they can start reaching for. Next slide. And then again, that trauma-informed care is, you know, that keeping that comfort rather than control, accepting everyone and valuing everyone, welcoming everyone. And I mean those most sincerely, making people feel welcome, and meeting the person where they are in their recovery process and listening to them. And you know, we have many people who come to us and they're not ready to stop using substances. And we just had a situation in one of our sites where a person came back 56 times. And 56 times we welcomed that person. We honored them. We listened to them. We helped them the best of our hearts. And on the 57th time they came back, they said, I want to try. And they went to, you know, a substance use recovery system, you know, I'm sorry, I'm blanking on the word that you call it. Anyway, that's when they chose to go for help for themselves. And if any one of those times we would have made them feel like, oh, you're again here, they wouldn't have come back another time. And so every time we have to be the best we can be with every single person, every time. And then, of course, you know, those trauma-informed key ideas of empowerment and choice, trustworthiness and transparency. Don't tell someone you're not going to do something and then do it. Always tell them the truth of what's happening. including peer support, is part of trauma-informed care. Thinking about safety, and I don't just mean safety for staff and people in a setting, I mean safety around their own, cultural needs, their own sexuality, their being able to feel safe in your environment because of the way it's set up, the way it looks. It's clean, it's inviting, it's friendly feeling. It doesn't have hard furniture that is discomforting to sit on. It says we care about you, the whole environment. And then keep in mind those cultural, historical, and gender issues that are trauma for so many people, and that they bring with them and we can't ignore. And then also making sure that we have that mutuality with people. No matter who we are, we can engage in mutual relationships with people we serve, because we're all in this together, really, we are. And COVID should have taught us that. Next slide. So this is the Project Redo is the seclusion and restraint services process that we have for reducing any kind of hands-on interaction. Next slide. And so what this slide represents is that you'll see that from 2017 until 2020, our census grew every year, right? But our hands-on events, and I'm not even calling them restraint anymore, seclusion, because our picture is something different. Any hands-on process we have with someone, we count. And that's not necessary, but that's the way that we've chosen to do it. And you can see how it went down. So it doesn't matter how many people you serve. It matters how you approach people. It matters how you give them space. It matters how you welcome them, how you create safety for them. And so this is a really important slide to think about, the numbers of people coming in, and yet the hands-on interventions went down. Next slide. Now, these next few slides are just about, restraint is going to go away. It is, because it's not a helpful practice. It causes trauma to people. And even if you think it's not causing trauma to someone, it is causing trauma. Because you think that they're not aware that they're in restraints. They are. And so go ahead and switch to the next slide. You're going to get these slides at the end of this. But look at SAMHSA is eliminating. They're committed to eliminating seclusion and restraint. Mental Health America urges abolition of seclusion and restraint, and prohibition of the use of sedatives and other medication as chemical restraints. NASHBID is ultimately eliminating the use of seclusion and restraint, and the American Psychiatric Nurses Association is looking for elimination of seclusion and restraint. So it's an old practice. It's an outdated practice. It doesn't bring value. And we happen to have Kevin Huckshorn on our team, and if you are paying attention to seclusion and restraint, you know her name. But she's done some really important work around this on how to reduce it and eliminate it. So you might want to look that up, Kevin Huckshorn. Next slide. And then this is our standard. RI International believes that all occurrences of seclusion and restraint are preventable. The use of seclusion and restraint has no therapeutic value and can have lasting traumatic effects on individuals. RI International is committed to and continuously strives to provide crisis services. Remember, these are emergency services with people in the highest acuity of challenges. And we are saying we're not going to do this. So provide crisis services free from seclusion and restraint. Next slide. And in our service centers, you see there's some paintings on here, and those are murals on our walls in different service settings. And almost all of our service settings now have these murals on their wall. And if you could look up close to them, they have hidden messages in them. And the lady that paints them calls it like, "Where's Waldo?" And they say hope. They say you are loved. They say never give up. They say you're strong, you're powerful, but you got to get close to the pictures to see them. And people, they get so much out of that. And one person came to her when she was painting one of these, and he said, you know, last night I was in my lowest spot, and I saw right above the sink where I was washing my hands, you are loved. And he said, I started to cry, and it gave me hope. And so just imagine 3 words, you are loved, can change someone's whole perspective when they're in a crisis. Imagine what your kind words can do for someone. Imagine that. Next slide. So we have this idea of no wrong door. And if I'm getting short on time, you can let me know, please.
Yeah, I think you're great, Lisa. Maybe, 10 or 15 more minutes and then have some time for questions would be awesome.
Okay. So we have this no wrong door idea, and that means that we don't say to someone, no, you're on substances, you can't come in here, or you're too aggressive, you can't come in here, or your acuity is too high, you need to go to the emergency room. And the reason that we do that is because people go to jail when we close our door to them. Often police officers will not go sit with them in the emergency room because they have other things that they got to get to out on the street. That's their job. And so when we say they can't come in, they take them to jail because that's a much shorter turnaround for them to get back out into the job that they're hired to do. Now, we hope that with 988, this is going to reduce, and people will be getting much more help in the community from mobile teams instead of, police officers, because we've sort of forced them into being mental health professionals. And believe me, many of them have become very skilled at helping in the community, but it's important for people to have care from people who've been trained to work with them. So until that changes significantly, we're going to say no wrong door when people come to us, because we don't want them to go to jail. We want to find ways to say yes. Next bullet. And we want to manage their medical clearance. In other words, we don't want them to go first to the ED, the emergency department, and then come to us, because they can spend hours in there. And a lot of times people are restrained to gurneys when they go to the emergency room if they are there for a mental health issue. And remember that restraint is a traumatic experience. So we don't want that to happen. So that's another reason we say no wrong door. We don't want to send people away because they have substance use disorders, but that requires our teams to know how to work with people who are using substances, and our docs to get familiar with how to care for those people, and our nurses to be, comfortable caring for people, especially if they're taking substances that are going to cause them challenges as they come off of them. We want to take people with the high acuity, and we want to do this because it helps to reduce stigma. It helps to stop sending people to jail. Next slide. So when we talk about comorbidities, and I think Dr. Chuck will want to change this because he's working on this language thing around substance use, and he's really trying to change that language. But we want to be sure that we are looking at all of our programs for mental health issues as dual diagnosis programs, and all of our substance use programs as dual diagnosis programs, so that we recognize that people who have engaged in substance use often have a mental health challenge, and people who have a mental health challenge often engage in substance use, because there's so many reasons for that. But in our society, it's kind of it's better to get help for a substance use disorder than for a mental health issue, people think. And so until that changes, we're going to still see people trying to manage their stuff with substances rather than getting appropriate mental health care when they need it. Next slide. So some of the things we have to be aware of when we're working with people are the protocols around methamphetamine use, alcohol protocols, opioid protocols, medication-assisted treatment, and that is such an important part of what we can do now is help people to get right to a medication-assisted treatment service so that they don't go through that discomfort when they're trying to stop using substances, which often causes them to go back to use. And we need to understand the protocols for benzodiazepines and for social detox situations on other substances. Next slide. And we want to also work with substance use challenges with a recovery focus. We want to look at all of the ways to care for them in treatment, care for them when they are experiencing intoxication, care for them when they have medical comorbidities, and especially when they are experiencing withdrawal. So that requires our teams to understand how to do this work. Next slide. So just we have to support staff with the education and support that they need to be able to be prepared for that. We have to help families understand how to help their loved ones effectively, understand the issue of substance use itself, help families to understand that so they can have, they don't have to be the one left out in left field without any understanding of what's happening to their loved one. We want to work with people with substance use disorders from strengths-based care, of course. Harm reduction tools are really important with substance use, and chronic illness management principles, and all of those immediate interventions so that we can act the minute that someone says they want to try, we can help them. Next slide. This is my my word cloud I made about language. These are not the words that we use, but it's the kind of language that we use when we do this work. And it should be compassionate and accepting and hopeful and caring and fun and open-minded, confidential, motivational, healing, positive, empowering, respectful. All of these kinds of languages, these kinds of words are the only things that should come out of our mouth when we're doing this work with people who are in need of our caring and our understanding. Next slide. So these are just some of my language that's not helpful. Case or user. Next slide. Not helpful to call people these things. Not helpful to call someone a borderline, or to say they're entitled, or that they're just attention seeking, or that they're unmotivated, or call them by their diagnosis, or use these kinds of slang words like crazy, nuts, and loony, or call them a frequent flyer. Because remember that person I talked about that came back 56 times? If they would have said, oh, he's a frequent flyer, it would have been all over them when they went out to greet him. Believe me, it doesn't just go away when you talk about people like this. It comes forward with you. So we don't want to say that, because every time someone comes to us, they've made the right decision. Decompensate. Let's talk about what's really happening for a person instead of saying they're decompensating, because to most people that I talk to who have lived experience, it sounds like we're telling them they're decomposing, like they're disintegrating. So next slide. And non-compliant, we have to look at things like unmotivated and non-compliant and wonder, are there things that we're doing that aren't working for this person, rather than just blaming them and saying they're non-compliant? How can we find a way to work together? How can we create a service system that's more motivational to help people be interested in trying? And we want to use this kind of language. Let's go forward. I just want to go through AIDIT really quickly. AIDIT is a tool that probably our clinicians on this call know about, but let's just talk through it. Go to the next slide, please. So AIDIT stands for acknowledge. And this means we want to greet our guests by their name. We want to ask them to enter their space. We want to smile. We want to be respectful. All of these things that are listed on the right-hand side. And because you're going to get these slides it's basically being present with them and letting them know that we see them. Next slide. The I stands for introduce. So tell them who you are. Don't just assume that they know who you are. My daughter is blind, and on her door, whenever she's in the hospital, it says, introduce yourself the moment you go in her room. We should do that for everybody. Who are you? Just because you work there doesn't mean that you don't have to introduce yourself to me, because I don't know who you are, maybe. Bring that goodwill. Next slide. Duration. Let people know how long it's going to be till they see someone, how long it's going to be until things are in place for them to get their housing. What will you do in the meantime to check back with them? All those kinds of things around duration. Will it be an hour before they see a doctor, or will it be 5 minutes? And if things are taking longer than expected, touch base again so that they know that you still haven't forgotten them. Next slide. The E stands for explain. Talk about what's going to happen, how it's going to happen. Ask them to ask you questions. Avoid talking in clinical jargon or any kind of language that, like, shortcut language or acronyms. People don't often know what those things mean, and we lose them. And that's not helpful. So we want to make sure that we explain things, we make eye contact, we take our time talking with them. Next slide. And T, thank you, stands for thank you. Be thankful for their participation. Say it to them. Be genuine and show your appreciation to them for participating, because sometimes it's taking everybody's courage, a person's huge courage to come and ask you for help. And so thank them for their belief in you, for believing that you can help them, for believing that you are valuable to them. So every time someone comes to us, we need to thank them for taking that risk. Next slide. So some of the things that block engagement that are not helpful are talking about people behind their back. Even if we think that people can't hear us or they don't know we're talking about them, as I said before, like when we talk in negative ways about people, it comes forward with us and it creates hostile feelings in us, and that will somehow show up on us, whether it's in our body stance, it's our face isn't relaxed, whatever it is. People sense something's wrong. They might not know what it is, but their trauma will tell them it's them. You're mad at them. You don't like them. Something's problem with them. And we don't want to create that kind of a situation for someone that we're serving. Next slide. And so it's important to welcome people, greet them, offer them something to eat or drink, especially if you're working in a crisis service. Many of the people that we serve maybe haven't eaten or had anything to drink for hours or days. And when we're kind and we are supportive, it energizes us and it energizes the people that we serve. When we come out with hope, we give them hope, they give us hope. So it's like this mutual exchange of positive energy. Next slide. And then safety, in our organization, safety is really important to us. And it's not just about our staff being safe, it's about everyone being safe. But everyone who's working in our service system needs to know their role. Everyone should be understanding about what are the tools that we need to use to help people feel safe, to engage them in ways that, inspire them to work with us. And we also want to give staff a means to voice their input around safety. So we have this button they can hit in their payroll where they put in their clocking in every day. They can hit a button if they don't feel safe. Next slide. And then, when people exit our services, we want to make sure that we follow up with phone calls or we bridge those connections to outpatient services. We send postcards to people. We want to support that connection to them. And these things can really help. Just like I had surgery a few days ago, and the nurse called me the next day to see was I doing all right. It was really just comforting to me to feel like somebody was still aware that I was out here. And that's what it feels like, because people are with us for medical needs. Yes, it may be about their mind or their substance use, but it's a medical need. And so we want to follow up with them after they've engaged with us and just connect with them. I think that's the last slide. Next slide. Oh, just the Brown Safety Plan is something that we're using, and we're actually training our peers to use this tool with Barbara Stanley and trying to help them to be able to do this. And it's much like a RAP plan, if anyone's familiar with RAP, but it's for suicide. And people make it, they tell you what they want on it, and they're very clear. You know, they have all the say in it. It's not something we create for somebody, the person creates it with you for themselves. Next slide. That's it. And there's Amy's address and mine. And please feel free to ask me
Thank you.
anything.
Yes, yes. Thank you so much, Lisa. That was fantastic. And I think probably spurred on a lot of thoughts for a lot of different people. So we'll open it up for questions for everyone or comments.
I'll start with a question. My name is Ray Michelson. I work for the Matsui Health Foundation, and I know that when we toured some of the sites there in Phoenix, Maricopa County, that we had heard that there were a significant number of mental health clinician call outs to schools. And I wonder if you'd comment on the peer interaction or the use of peers when it comes to those school calls.
So I don't know specifically about that, but I can imagine that there's call outs. Amy, if you know more, you can. But there's a huge push right now to train young adults to be peer supporters for children and young people. Anybody working with children needs to be safe to work with children, including any peer supporters. And I mean that most sincerely. But I do think that peers would be great in that environment, especially if the young people perceive that person as being in their world. They would open up more.
Yeah, and I don't have anything to add. I'm not sure, Ray, it might have been maybe your conversations with law enforcement or the mobile crisis team when they were talking about that, depending on that, because they do definitely respond out to schools and anyone. They have a whole youth and adolescent mobile team that responds out, and definitely peers are part of that mix in their staffing pattern as well. That's not our agency that does that. That's a different agency that does the mobile teams, but definitely part of the whole continuum here in Arizona. So if you've been here and done the immersions, you'll see every level of care, from the call center hub to the mobile crisis to the facility based. And so you would have heard that, but they do have peers on their staff. So it's a 2-person team with peers or BHTs, behavioral health techs, and a clinician that responds out to all of their calls.
And I happened to have called them last year sometime to find out how many calls peers would go out on, and it was thousands. So they are integral members of those mobile teams. They're not extra people. They are right there. You can ask me any question.
Hi,
And thank
Lisa
you.
and Amy. Thank you for the presentation. My name's Dave Branding. I'm the CEO at an organization called Jammy Health and Wellness in Juneau. And our organization, from the CEO's position at least, seems to be quite recovery oriented. We're pretty progressive in the way we do a lot of things, I believe. But one thing we've not been able to be consistently successful with is attracting and retaining a strong peer workforce. And when I look at it from my position, I think we have good supervisors. A lot of people work at the organization who have lived experience, but this is an area that we're just not achieving strategically like I think we should be. How should an organization like that be self-assessing itself in a way to help us improve?
So that's such a good question. We have developed a tool actually to measure your peer poweredness. And it's just being spiffed up a little bit to look better. So we can send you that. But also, you know, some of the things that I hear that are challenging is pay scale for people. Because when people come off their benefits and things, it can be really scary. So we have to make sure that there's this balancing act in the beginning. And a lot of people, what I've seen over the years is they go half time and they need to keep their pay under a certain amount. But I think as soon as they feel like they can go full time and get benefits and everything like that, it's just really important to give them the full scope. And if you are, my hat is off to you. I congratulate you for that. The other thing is that sometimes it's challenging when there's not enough training going on to get the numbers of people that need to be available to fill these roles. And I don't know how much training goes on in Arizona. I'm sorry, I'm not aware. But I know in Arizona we have many trainings. And that is the way that we can keep the numbers of positions that are opening up for peer supporters available. If you have one training organization, it would be important that they be funded enough to have multiple trainers, so that enough training can take place. So if you have a state that has one facilitator, it may not be able to do the whole amount, but expanding that would maybe help build that pipeline.
Good, thank you. Yeah, I'd be really interested in the peer poweredness tool.
Yeah, I'd be happy to send that off to you guys.
Thank you.
I'll send it to you, Becky.
Yeah, that would be great if you share that with me, and I can make sure it gets over to Dave and any others who might be interested. Thanks so much, Lisa.
You're welcome.
Hi, Lisa. My name is Sam Garcia. I am the peer manager for Henning here in Alaska.
Hi.
And so I'm really excited about some of the things you guys are doing down there. I've heard a bit about it. What are some of the challenges you have faced with, I guess, peers in the mobile crisis team to the centers to implementing your Crisis Now movement?
I think I think often what happens is that it hasn't happened with us for a very long time, because we've been employing peers since, for 23 years now. But in the beginning, if they were not feeling welcome where they went, like if the teams were very standoffish and things, or they didn't, actually in a hospital, when we first took peers in a hospital, this county hospital here, the nursing team was not happy about it. So they didn't welcome them in. They were really uncomfortable. And one night, one of the team members called me and said, the nurse won't let me off the unit. I'm done with my shift until everybody goes to dinner. So she made that peer who was there for work stand in the line with everybody who was going to go to eat. So those kinds of aggressions, right. And, sometimes they're very subtle aggressions and things like that can happen and be really challenging. But it happens typically when team members, other staff members are not sure, what are the peers going to do? What are they there for? Am I gonna have to take care of them? Those kinds of negative thinking. And peers, I mean, let's face it, a lot of us have trauma in our history, so we're very much like surveying the environment constantly. So we're picking up on things that maybe they think they're hiding really well, but we sense it. We sense there's some kind of angst in the air.
That makes sense. I've seen that a little bit here in Alaska, but I've been grateful and blessed enough to work for some pretty great places. And so we have, you know, like our case staffings and everything, and worked alongside clinicians and counselors and everybody on a treatment plan. And for the most part, like, you know, along with the right training and everything, we feel a part of, I would say. So that's
So
Thank you.
glad to hear that. Because sometimes, you know, don't you find like if you're in a case planning or something, that sometimes you can bring a different perspective to something simply because maybe you had a similar experience and there's things that you know that maybe somebody who hasn't had that kind of experience doesn't quite
Mhm.
understand yet.
Yeah, we'll be able to see things from a different perspective, and lots of times participants will share things with us in a different way they would share with anybody else. So we get to see a different
Exactly.
side.
Exactly. There's an ability to build trust that is present in peer supporters. That's like something amazing to see. They build that relationship so quickly. And then they can use that relationship to bridge back to the other team members and create safety there for people. Thank you for that, Sam.
Thank you. And thanks for the work you guys are doing.
Thank you.
As we're coming to the end of our time, I wanted to see, and you know, there's a lot of you know, great work going on in Alaska related to peer support certification and some you know, new training opportunities. I know we have Lisa Cobble on with the University of Alaska Training Cooperative. Lisa, I don't know if you want to share anything about some of what your team has been up to.
Yes, thank you very much. And first, I want to say thank you, Lisa, for an outstanding presentation. Really great to hear what's happening, and again, reminding us about peer empowerment. Really appreciate it. I wanted to say that we've been working on the peer-centered crisis response workforce training, and it is ready to launch. The College of Health and the Simulation Center at the University of Alaska Anchorage has come together to create a wonderful simulation training to provide peer support specialists an opportunity to experience working in a call center, on a mobile crisis team, and in a living room model 23-hour stabilization center. By using the simulation lab, peer support specialists can receive safe practice opportunities paired with clinicians and other responders in various crisis scenarios. A successful pilot of the training occurred this last June, and then all of the stakeholders involved were able to give feedback, and edits from that feedback have been made to the training. A wonderful peer served on the planning and training development team and observed the pilot and was able to really ensure peer input and feedback. The training is ready and outreach is underway to determine interest in participating in the first session. And we hope to do scheduling in the early spring. An announcement will be coming out in December about these spring opportunities for continued simulation center training. So that's the good news that we have to share from UAA and the Center for Human Development.
Wow, that sounds wonderful. Yay.
Great work, Lisa. That's amazing.
Thanks so much for sharing, Lisa. I think we have time for one or two more questions if anyone else wants to jump in with any questions, or just want to share anything that's any initiatives here in Alaska that you want to provide updates on.
Hi, my name's Brenda McFarland. I'm the Crisis Now Coordinator for Fairbanks, Alaska. I did have a question. I've been just talking with people about using peers in very small communities, in rural areas, places where everyone might know everyone or be related. And someone, you know, in the first responder community kind of responded that that might be kind of hard for the peer to go out with this person in crisis, and then that person knows they're going to have to see that person, you know, every day continuing. Is there any experience RI has around that that we could kind of use to still support this idea?
So, so over the years, yes, there's been a number of times when we've had people who have come in for services who know one of our peers, that this is the closest that I can get, and engage with them frequently. Okay, so what we did is that person wanted to work with that peer, and it's really their choice. Do they feel comfortable with it or not? And then we talked to the peer. Is the peer comfortable with that? And then what we did was we sat down together and we laid out a plan in this particular situation. And this is the one that's coming to my mind because it's just there. So is we, sorry, I'm trying to block a cough. We helped them to make out a plan for how they wanted to go. So the peer said, when we're together and we're doing the other things that we do, which is they used to make rosaries together. We don't talk about what we do when I'm your peer supporter. And when we are together, we don't talk about making rosaries together. So in other words, what it was a delineation of the two experiences. And of course, as a peer, you know, you can't talk to anybody about what you do with that individual, right? So whatever that person tells that peer should be safe with them, and that peer should be really queued up to that, just as any clinician would be that would be in that same environment, as to not share that, so that there's safety. But I've seen it work really, really well. And that's why, you know, it's just about really being clear. What are the boundaries that are going to exist here? I hope that helped.
It did. Thank you
so much for that great example and advice, Lisa, and really thank you, Lisa, for this amazing presentation, and Amy for helping to coordinate and get us connected. We're really looking forward to continuing these learning opportunities on a monthly basis starting in January. So stay tuned for additional invites. And we will be sharing out the recording and the slides from today via email. And then also at some point they will be posted on the Trust's website, I believe is the plan. So if you don't get them via email, please reach out to me, and also can check on the Trust website at a later date. So thank you all so much for your time, and we'll see you next time.
Thanks, everyone. Bye.
Great work.